Madam. Good evening, everyone. Welcome to another episode of Young Family Physicians Forum. Today, our speaker is Dr. Gayani Minuwanpitiya from the 2023 Registrar batch. I invite Dr. Nimasha Silva from the same batch to provide the introduction for her. Over to you, Dr. Nimasha.
Thank you. Dr. Gayani Minuwanpitiya graduated from Faculty of Medicine, University of Ruhuna in 2019, and she completed her internship in 2020. Currently, she is a first-year registrar in family medicine. Over to you, Gayani.
Thank you, Nimasha, for that kind introduction. So today, the topic that I've chosen will be revealed in a bit. So hiding in plain sight. We'll start off with a case history. So Mr. A was a 65-year-old retired clerk who had a history of hypertension and dyslipidemia for the past 4 years. And the reason for encounter this time was epigastric pain for the past 2 months. So this pain was dull and vague in character. It was exacerbated following meals. He did not really recall it radiating to any site in particular, and there was no association with exertion. However, along with the pain, he experienced postprandial fullness, belching, heartburn, and a loss of weight, which seemed a bit alarming at the time. So, prior to this, he does not recall having similar symptoms in the past. And he has sought treatment from the hospital OPD, where he was treated with omeprazole and famotidine several times, which only provided a temporary relief. So at this point, what I was thinking is, what could this be? What differential diagnosis should I consider in this clinical context? Could this be plain and simple gastroesophageal reflux disease? Or is it a peptic ulcer that's causing him all this trouble? Could it be a drug-induced dyspepsia?
What you have to do is, you have to involve the audience.
Okay, madam.
You really want to just now skip the slide. Now you have to ask the audience to give the differentials. Otherwise, you just talk. The others, of course, just listen. That is how seniors does. After all the examination findings, also you better ask the differentials, right?
Yes.
Better ask from.
Okay.
Also with the people, you have to contribute for that.
Yeah. Okay, madam. So now, considering this presenting complaint, what are the possible differential diagnoses that will come to your mind? Would anyone like to contribute?
Is he a non-alcoholic, Dr. Gayani?
No, I will come to that later.
What about her appetite?
Appetite was
not. Don't ask any questions. With the available data, you should give the DDs right now. Then the next step is, after giving all the other sort of information, then you have to again work it out. Otherwise, it's not working. If you give all the sort of details, so then we can narrow down. Of course, it's true. But anyway, then and there, you have to get the broadly, what are the differentials for this? That is how all the seniors did the past few months or the years.
Okay. So what are your thoughts at this point?
Pancreatitis, on chronic pancreatitis.
Okay.
CA stomach.
Yes, a cast cancer of the stomach.
It could be a pancreatic CA or liver CA.
Yes, those are also possible differentials.
Peptic ulcer disease.
Yes, of course, peptic ulcer disease, because again, common things are common. Any other differentials that come to your mind? Okay. Well, keeping these contributions in mind, as I said, common things are common. And could this be gastroesophageal reflux disease? Could this be a peptic ulcer? Could this be a drug-induced dyspepsia? Could this be mesenteric claudication? He has dyslipidemia and hypertension. Could be due to atherosclerotic cardiovascular disease. Could be a component. Or could this be gastroparesis, which again can be seen in older age? And most importantly, could it be something quite sinister, like a malignancy, like most of you all guessed? Could be stomach, pancreatic, and even hepatobiliary as well. So keeping these differentials in mind, I explored the history further. He did not have a history suggestive of biliary colic, and the history was not, suggestive of angina, intermittent claudication, a past history of TIA or stroke, which could point towards the presence of atherosclerotic cardiovascular disease. There was no history of diabetes, and he has recently gotten a fasting blood sugar done, which was 90 milligrams per deciliter. There were no recent viral infections or symptoms suggestive of an autonomic neuropathy that can point towards the presence of gastroparesis. In his drug history, other than 50 milligrams of losartan twice a day and 20 milligrams of atorvastatin taken in the night, he was not taking any long-term medications. To explore the red flags, other than the presence of loss of weight, he did not experience any early satiety, loss of appetite, nausea, vomiting, dysphagia or odynophagia, history of upper GI bleeding, any alteration of bowel habits, while there was no family history of GI malignancy as well. To explore the effects it had on his daily activities, the main difficulty he experienced was an aversion to food due to the postprandial discomfort he experienced, rather than a loss of appetite. In his past medical history, as I mentioned previously, he had hypertension and dyslipidemia for 4 years. Other than a lipoma excision, there was nothing else significant in the surgical history. He had no known allergies. In his family history, there were first-degree relatives with non-communicable diseases like diabetes mellitus, hypertension, and stroke. But however, as I mentioned earlier, there was no family history of GI malignancy. His diet was a pescatarian diet, meaning he only consumed fish and not meats. However, he does not consume as many fresh fruits and vegetables because it has not been a habit he has had since his childhood. To talk about his social background, he's a retired clerk, he's married, and his wife is a retired teacher. He had 2 sons who are married and living separately. He's a past smoker, abstained for 4 years and 6.5 pack years of smoking. He's a social drinker, and at the moment, he did not have any significant life stresses. Keeping these things in mind, I explored his ideas, concerns, and expectations. So his idea was, this is probably gastritis, as most people come and tell us, because any discomfort or any complaint they have related to the upper GIT, they label as gastritis. But one of his major concerns was the possibility of a sinister pathology considering his age. And what he was expecting from me was mostly reassurance because he was, as he said, he was getting used to the symptoms. In his examination findings, nothing remarkable was actually found. His BMI was 20. There was no paloicterus or cervical lymph nodes. Cardiovascular examination was normal. Abdominal examination only showed a mild tenderness in the epigastrium, which was quite non-specific. There were no palpable masses, including hepato or splenomegaly, and no ascites as well. Examination of the respiratory system too was normal. So considering this history and examination, what do you think? What are the possibilities? Would anyone like to share their thoughts?
GORD may be high in the list.
GORD, okay.
Here, 3 registrars, please talk.
Anything else?
Chronic pancreatitis.
Okay. Anything else? Any other differences that come to your mind considering the history and the examination?
With the history of smoking and of appetite, malignancy is also possible.
Yes. Yes. Any other thoughts? Okay. We did have a few contributions through our brainstorming session. So my thoughts at this point were, this was a 65-year-old male and he was presenting with new onset dyspeptic symptoms and epigastric pain, and he had loss of weight. Now, these points that I have put in red, they are what we call as red flags. And any patient presenting with red flags at this age would need an upper GI endoscopy, was my thought. So I discussed about my patient with my trainer and we came to the same conclusion. So how did we manage him? First up, we educated the patient about the possibilities and explained to him why it is necessary for him to undergo an upper GI endoscopy. But for symptomatic relief for the moment, we prescribed him with omeprazole 20 milligrams mane and domperidone 10 milligrams 3 times a day, and referred him for an urgent upper GI endoscopy with plans for a review. So what do you think we may have seen in his upper GI endoscopy? What are the possibilities? Any thoughts?
Peptic ulcer disease, malignancy.
Okay. So at the review, His upper GI endoscopy revealed a suspicious-looking growth in the gastric antrum, the histology of which showed intestinal-type gastric adenocarcinoma. So this is not the exact image of the patient, but what you see here is a growth in the gastric antral region. So what are the important points of consideration in this patient's history? At a glance, his symptoms seem quite non-specific or does not sound very sinister. His examination was unremarkable except for some epigastric tenderness, which again is non-specific. And the decision made for referring for an upper GI endoscopy was solely based on the presence of red flag symptoms. So, keeping these things in mind, let's move on to the topic of the day, which is an overview of gastric cancer. So, during the rest of the discussion, I will give you an introduction into gastric cancer, discuss a bit about the epidemiology in a global and local perspective, discuss about risk factors, the clinical presentation and management in brief, and finally, and most importantly, the role of the family physician in the management of gastric cancer. So gastric cancer is the 5th leading cause of cancer worldwide. So it has been described as early as 3000 BC in hieroglyphic inscriptions and papyri manuscripts from ancient Egypt, which means it is something significant enough to be mentioned in historical records. And it's one of the most common causes of cancer deaths in the world. The prognosis of gastric cancer is generally poor, and this is because they are generally at an advanced stage at presentation or diagnosis, because the sinister symptoms we look for become quite evident only in the latter stages. Therefore, early diagnosis is the key to success with the management of this disease. As I said, it's the 5th leading cause of cancer worldwide. And males are affected twice as females. And another important thing is that the incidence of gastric cancer varies greatly according to the geographic region. It's quite common in regions like Eastern Asia, Japan, China, South America, but less incident in places like North America. And what they have also observed is that migration can lead to a change in risk. For example, someone living in a high-risk region migrate into a low-risk region, low-incident region, will reduce their risk, mostly in the subsequent generations. So what that postulates is that the lifestyles adopted in these regions are probably affecting the local disease patterns. And another factor that has been observed is that the global incidence and mortality has declined rapidly over the past few decades. And this could be due to recognition of certain risk factors such as Helicobacter pylori and other dietary and environmental risks which can be prevented or intervened with. So when you take a look at this graph, it shows a region-specific incidence of gastric cancer. So as you can see here in the top is East Asia, where the incidence is almost as double as the Eastern European regions. So where is Sri Lanka in this graph? Southeastern Asia. So again, what you can see is that the incidence in the males is higher than in the females. And in considering our region, with comparison to higher risk regions, the risk is about 4-fold less. Or I would say incidence is about 4-fold less. When you consider the incidence in Sri Lanka, it reflects the global patterns where males are affected twice as the females. And the commonest site that's affected is the cardia of the stomach. And during the year 2021, 420 new cases were detected in males and 205 new cases were detected in females. Considering the age-specific incidence rates of stomach cancer, you can see that it shows a rapid rise after the ages of 40 to 45. And you see a peak here in the age group 65 to 70, which means this is mainly a malignancy occurring in older age. And this is actually a reflection of the incidence over the past about 15 years. And what you see is a gradual rise in the incidence in both male and female. The female rise is a little at a lesser rate than the males. So that was about the incidence. And what about the deaths? The proportion of leading cancer deaths is recorded in one of the vital registration systems in this country. And these are a representation of all the cancer deaths. So in females, if you take a look at it, stomach cancer accounts for about 2% of cancer deaths, whereas in males, it accounts for about 3% out of all cancer deaths. So this was a study conducted by a group of investigators in Sri Lanka with regards to the outcomes of patients with esophageal and gastric cancer in Sri Lanka. So what they concluded in the end is that the outlook was poor in patients diagnosed with esophageal and gastric cancer. And what could improve the outcomes of these patients? The early detection and greater utilization of multimodality treatments. So early detection plays a vital role in reduction of the mortality and morbidity of these patients. So what are the risk factors? The risk factors could be environmental or related to the host. So I think we are aware of some of the common risk factors. Can somebody contribute?
Dietary habit like eating more red meat.
Yes, that is one of the known risk factors. Alcohol?
Fish.
Yes.
And patient with blood group A.
Yes. That again is a proven association. Okay. So out of the environmental factors, chronic Helicobacter pylori infection is very strongly associated with cancers occurring mainly in the distal stomach or in the pyloric region. So what happens is with chronic infection, there's a cascade of changes that happen, which ultimately ends up in carcinoma. And this is characterized by the histological features of these different stages. First, it would be a non-atrophic gastritis, followed by atrophic gastritis, metaplasia, dysplasia, and ultimately developing carcinoma. So this process takes a long period, which means the infection has to last a long time. So this is a point at which we could all intervene by Helicobacter pylori eradication. Geographic location, as I said, is another risk factor. And this is highly prevalent in regions like East Asia, Eastern Europe, and South America. Diet, especially salt and salt preserved food, N-nitrous compounds those are cured meats, smoked meats that can contain these nitrites and nitrates, which are highly associated with development of stomach cancer, and also low folate levels. So these are risk factors. Some of the dietary factors which are proved to be protective are high fiber content in diet and consumption of plenty of fruits and vegetables which are high in antioxidants. Certain occupational exposures like coal, tin, rubber, and steel manufacturing are also associated, as alcohol, smoking, obesity, infection with Epstein-Barr virus, and low socioeconomic status. So what are the host factors? First-degree relatives have a threefold higher risk of developing gastric cancer. So this actually has two arms. One is families have a risk of acquiring Helicobacter pylori infection together. So they develop that risk factor in one way. And the other reason is genetically inherited conditions like hereditary diffuse gastric cancer, familial intestinal gastric cancer, Lynch syndrome, hereditary polyposis coli, juvenile polyposis, Peutz-Jeghers syndrome, just to mention a few. So these inherited types tend to occur at a younger age and tend to have a poorer prognosis. So age again is a risk factor. As we said, increasing age is a risk factor. The median age at diagnosis is around 70 years from what has been observed. A history of abdominal irradiation for malignancy treatment is again a risk factor. As one of our trainees correctly mentioned, blood group A, individuals with blood group A shows a 20% excess in incidence of gastric carcinoma. So what they have found is that this is likely due to the effects of genes closely associated with blood group antigens. Prior history of gastric ulcers and gastric surgery both are risk factors, and so is pernicious anemia. So now that we have talked about the epidemiology and the risk factors, let's see how we can classify gastric cancer. So first up, we classify them according to the anatomic location. So true gastric cancer is referring to the cancers occurring in the regions other than the gastric cardia. And the other type is tumors arising from the gastric cardia, or they are also known as gastroesophageal junction tumors. So these two have very significant, very peculiar patterns of incidence. So those occurring in the pyloric region or non-cardia type are strongly associated with factors like Helicobacter pylori infection, whereas gastroesophageal junction tumors share some characteristics with lower esophageal adenocarcinomas and are more associated with other risk factors like smoking, alcohol, like risk factors. Now, this is the anatomic classification, and histologically we broadly classify them as adenocarcinoma, which account for about 95%, and the other types, which are lymphomas, carcinoid tumors, gastrointestinal stromal tumors, which all together contribute to about 5% of all gastric cancers. So gastric adenocarcinomas have been historically classified according to the Lauren classification as intestinal type, diffuse type, and mixed type. So mixed type consists of features of both intestinal and diffuse type in histology. So intestinal type is more common in males and old age groups and more prevalent in high-risk areas. These are sporadic cases, and the distal part of the stomach is more commonly involved. The diffuse type, on the other hand, is equally frequent in males and females. It's more common in younger age groups and mostly hereditary. The intestinal type mostly involves the distal part, and the diffuse type commonly involves the proximal part of the stomach, and the prognosis is much worse than the intestinal type. Now you see a few other newer classifications that have come up, and the latest one that is used mostly now is the WHO classification, which further divides these types into many different types. These are important in the management. The other classification important for us in the management is the TNM, or the tumor node and metastasis classification, which is important for the staging of the tumor. T stands for primary tumor extension, N for presence of lymph nodes, and M for the presence of metastasis in distant organs. So which sites are commonly involved? So historically, the gastric cancer was the most common site of involvement. But however, since recently, tumors of the proximal stomach have become more incident. This is more commonly seen in developed countries. So these share demographic and pathological features of Barrett's-associated esophageal adenocarcinoma, as I mentioned earlier. They are more likely to occur in males and tend to be more aggressive than the distal types. This is not associated with severe forms of gastritis that are characterized by atrophy or intestinal metaplasia, which we see with Helicobacter pylori infection. And environmental factors, especially chemical carcinogens, are more strongly associated with this type of cancers. So how would a patient present? This is very important for us as family physicians because these patients present to us most of the time for the first time. We are the first contact. So it is important for us to recognize which symptoms may prompt us to think of a possibility of a gastric cancer. So most patients are asymptomatic, and when symptoms are present, they are quite non-specific. And physical signs may be absent until the disease is quite advanced, like in the case of our patient who only had some non-specific epigastric tenderness. So what are the common symptoms they can have at presentation? Most of them present with weight loss. And this is usually a result of insufficient caloric intake rather than increased catabolism, which you would see in cancer cachexia in late stages. So weight loss can be attributed to abdominal pain, early satiety, like our patient had. He too had an aversion to food due to the discomfort he felt. They can have vague abdominal pain, and mostly it's felt in the epigastric region. And it may not even be bothersome at the early stages. Dyspepsia, especially new onset. They can have bloating, early satiety due to the presence of the tumor mass, which causes the stomach to feel full. They can have fatigability. And dysphagia may be seen with the involvement of the cardia. And it may be due to the involvement of the esophagus as well. And another reason is a pseudoachalasia syndrome that may result due to the involvement of the orbital plexus with local extension around the gastroesophageal junction. They can present with occult GI bleeding. So if we do a stool for occult blood, they may have some they may show evidence of occult bleeding. And in advanced stages, they can present with hematemesis and melena as well. Complications like a gastrocolic fistula may rarely prompt the patient to present with a feculent emesis, colonic obstruction, or sometimes perforation of the stomach as well. So physical signs, as I said, are generally seen in late stages. So pallor may be a result of anemia due to chronic blood loss from the tumor. Jaundice due to metastasis involving the biliary tree. Left supraclavicular or the Virchow's node enlargement, which we learn as medical students quite enthusiastically, is known as the Troisier sign. It signifies distant metastasis. Palpable abdominal mass may be felt in advanced stages. Hepatomegaly, shortness of breath or a pleural effusion, ascites are all signs of distant metastasis. Ascites due to peritoneal carcinomatosis. So a succusion splash is what will be evident when there is gastric outlet obstruction causing stasis of food in the stomach. So periumbilical mass may be a physical sign that's observed due to skin metastasis, which is known as the Sister Mary Joseph's nodule. And sometimes they may present with an ovarian mass due to metastasis. This is called a Krukenberg tumor. So, some uncommon presentations that we may encounter are maybe due to paraneoplastic phenomena. So, Dressler-Trilak syndrome is a condition where there's a sudden development of large number of seborrheic keratoses. So, if you ever see a patient like this, it should prompt you to think, is this just pure and simple seborrheic keratosis or something else? And acanthosis nigricans is also associated with gastric carcinoma. They can present with microangiopathic hemolytic anemia, membranous nephropathy, or vasculitis, such as polyarteritis nodosa. So, what are the complications you may see with gastric cancer? They may be due to the tumor itself or due to metastasis. This is important to know because this could again be a presentation, as I said. So, common complications of the tumor would be bleeding, which could be occult or revealed, perforation of the stomach, gastric outlet obstruction, and fistulation, causing gastrocolic fistulae. Metastasis will produce site-specific complications, and the common sites of metastasis are lungs, liver, bone, and brain. So, how would you evaluate a patient with gastric cancer? So, investigations are not just for diagnosis. They are important for staging, assessment of complications, and preparation for treatment as well. So, staging is important to decide whether this is an operable tumor, and if operable, what surgery is best suited for this patient. So, for diagnosis, the investigation of choice is direct visualization with endoscopy, esophago-gastroduodenoscopy, followed by biopsy of the mass. So, this will provide a tissue diagnosis when we take a biopsy and look at the histology, and also help us to anatomically localize the primary tumor. So, early use of upper endoscopy in patients presenting with GI complaints is associated with a higher rate of detection of early gastric cancers. That is why we need to be very vigilant about the red flags. So, barium studies, barium male is rarely used now, and because 50% of the time there can be false negatives. So what you see here is the endoscopic appearance of a gastric carcinoma. So they look like this polypoidal growth, which may have some necrotic areas, ulcerations. And during endoscopy, you can take a biopsy directly from the mass and look for the histology. So for staging, what investigations are used? The European Society of Medical Oncology recommends all patients to undergo contrast-enhanced computed tomography or CECT of the chest, abdomen, and pelvis to detect the primary tumor and its metastatic involvements. Endoscopic ultrasound is recommended for patients with no evidence of metastatic disease on CT, and this is to identify locally advanced disease. That is, how far along the gastric wall is it involved, or are there any local lymph node involvement. PET-CT is indicated in patients who are metastasis negative in CECT with stage more than or equal to T2 N0. This is to screen for distant mets that may not be evident in the CT. And all patients fit for surgery are recommended to undergo a staging laparoscopy to detect the presence of peritoneal mets, because that will change the course of treatment. So other supportive investigations are full blood count, a liver profile including ALP to detect the presence of involvement of biliary tree, and renal profile. So when it comes to the management of gastric cancer, it's going to depend on the stage. If it's a localized node-negative gastric adenocarcinoma, resection of the primary tumor itself may be curative. If it's locally advanced, that is, there is involvement of local lymph nodes or infiltration into surrounding organs, the surgery is done with an intent to cure or for aggressive palliation. However, when the disease is advanced with distant mets, symptom palliation and possible extension of survival is the goal of treatment. So for management, a multidisciplinary team approach is taken. So gastroenterologists, GI surgeons, oncologists, family physician, palliative care team, physiotherapists, and also psychologists and nutritionists are involved in this multidisciplinary team approach. So the treatment options are going to again depend on the cancer stage and the histological type. Surgical resection may be with intent to cure or palliation. So palliative surgical resection may be to relieve a gastric outlet obstruction or excision of a perforated viscous. Chemotherapy, which may be adjuvant or neoadjuvant. So generally, this is recommended for locally advanced or beyond. Radiotherapy, again, adjuvant or neoadjuvant. And there are targeted therapies that are based on specific biomarkers. So unresectable or metastatic tumors, which are HER2 positive, can be treated with trastuzumab and pembrolizumab. And HER2 negative patients with gastric adenocarcinoma who are positive for PD-L1 can be treated with nivolumab. These are all biologic therapies. So now that we have talked about the incidence of gastric cancer, the epidemiology, risk factors, how they present, how to investigate a patient presenting with gastric cancer, and how to manage in a very short context, what is important for us is to know the role of the primary care physician in the management of gastric cancer. So, what do you think what do you think us as family physicians can do to involve in the management of patients with gastric cancer? Any ideas?
We can provide long-term follow-up for the patients who have been
Yes.
diagnosed and treated.
With what intent? Long-term follow-up.
To identify any symptoms of recurrence and then to re-refer, or
Yes. Yes. What else can we do?
Coordination of care with the other team
Yes.
who are involving.
Yes, that is very important. Coordination of care. Because these patients, especially if they need palliative care, are going to need finely coordinated care in order to provide them with a better quality of life. Yes. Okay. So the role of the primary care physician starts actually from primary prevention. Now that we know what risk factors can point towards a future occurrence of gastric cancer, we can identify patients with risk and provide them with advice to go towards primary prevention. Then at-risk patients can be screened, but however, this is not something routinely practiced in Sri Lanka at the moment. Early referral for endoscopy upon suspicion is quite important to detect this malignancy at an early stage so that the prognosis can be much better. And the next thing is coordination of care and survivorship planning, including palliation. This is a very important role we have to play in the management of not only gastric cancer, but any patient with a chronic debilitating illness. So this will involve a multidisciplinary approach to the management of the active disease. We can organize family meetings, management of long-term sequelae of the disease or treatment, and providing end-of-life care. So we have to identify patients with risk factors, as I said, and engage in primary preventive measures. So dietary advice that we can provide to patients would be to avoid pickled food, salted meats and fish, smoked and processed food as much as possible, and consumption of a diet high in fresh fruits, vegetables, and fiber can be beneficial. Avoid tobacco smoking, avoid alcohol or stick to a safe limit, address obesity with weight reduction, with diet and physical activity, treat H. pylori infection. That is quite important because it's strongly tied to the development of adenocarcinoma in the distal stomach in later life. And also refer patients treated successfully for a gastric ulcer for repeat endoscopy to ensure healing, because a poorly healed ulcer might actually mean it's a malignancy sometimes, because they can present like an ulcer even rather than a mass. So what is the role we have to play in the palliation of these patients? So to understand that, it's important to know that palliative care begins at the time of diagnosis and it continues throughout the disease process until death and into the family's bereavement period as well. This is aimed at controlling symptoms, whether from the cancer itself or the toxicity of treatment delivered concurrently with the disease-directed therapy. So while you are treating for the disease with the specific therapies, you try to make life better for the patient. So as I said, family physician must work in coordination with other healthcare professionals, which we all know is shared care. And this should always be patient-centered and patient-tailored. It's going to be based on the needs of the patient. And the prognosis of the patient is not what we take into consideration here. And one other important thing we need to keep in mind is that palliative care is not for advancement or postponement of death. So the main aims we have here is to relieve symptoms, improve their quality of life, and address emotional and spiritual concerns of the patient and the family, both the patient and the family. So cancer survivorship is a concept which describes the experience of living with and beyond a cancer diagnosis, including the needs, health, and challenges of the patient and their caregivers. So this is an important concept. So I don't know whether you have encountered this. So this is a shared care clinical record that is used for cancer patients. Now it has been introduced by the Ministry of Health along with the palliative care program for cancer patients, where you will see these contents in this book. So it has a section for primary notes at the primary medical care institution, home-based care. So these are actually going to highlight the things that we will have to do for these patients. So before we decide on providing palliative care or making the life more comfortable for the patient, you need to conduct an assessment. Now, this is done frequently by the specialists who manage the disease itself, oncologists and the surgeons. But at our point of care too, we need to make an assessment of these patients. So these have to be done at key transition points of care, and it's an ongoing process. It's not only at the diagnosis. So at the diagnosis, as I said, you have to make an assessment. And when there's a significant progression or exacerbation of the disease, and if there's a significant change in the patient's family and social support, at the patient or family's request, if they are requesting a change in their care, a significant change in the patient's functional status, and as the patient enters the terminal phase or the end of life, we need to make an assessment so that we can provide a better care for these patients. So what are the things we are going to assess? The symptoms and discomfort experienced by the patient. Their functional status. We could use something like Barthel Index or activities of daily living and instrumental activities of daily living. Assess their psychological status. What are their fears? What is their mood like? What are their worries? Adjustment to the illness. How well are they adjusting to it? About anxiety, depression. Are they having suicidal ideation? Any pre-existing conditions that can actually make their psychological status worse? What are the aggravating factors? And most importantly, what are the strengths and resources they have for their mental well-being? Social aspects also need to be assessed at key points of transition about their family and relationship, finances, occupation, recreational, and what is their role in the community. And last but most importantly, their spiritual and emotional well-being is very important, and this is an aspect with which the family physician can very well be involved. You can always ask what are their sources of hope, personal spirituality and practices. We can encourage these things. And what effect do these beliefs have on their treatment and end-of-life care? So these are the aspects that need to be assessed. So how would you manage long-term sequelae of the disease and no treatment at our level? So the disease itself can bring about symptoms like weight loss, poor appetite, gastric outlet obstruction, dysphagia, fatigue, dyspnea, dehydration, and pain. So post-treatment too, they can have complications like chemotherapy-induced neuropathy, post-gastrectomy complications, psychological impact, and of course, the financial burden may be on both the patient and the family. So how to address these at our level? So with regards to nutrition, these patients will have a lot of GI symptoms. If they do not undergo any surgical treatment, their appetite is going to get lesser and lesser. So we need to educate the family and the patient regarding good sources of protein to minimize the effects of cancer cachexia. And also it is quite important to maintain good hydration. Consider oral supplementation of micronutrients wherever necessary. And the opinion of a dietitian can also be sought whenever you feel necessary. So most patients after gastrectomy, when successful anastomosis cannot be done, will have to be put on enteral feeding. This may be a peg tube or a jejunostomy, and can be quite frightening to the patient and the family too. So we could actually help the patient and the caregivers to learn how to feed them, what are the techniques, how to care for the feeding tube, and refer whenever you see a complication. And then the complications that you can look for are infection, tube dysfunction, inadvertent tube removal, bleeding, peristomal leakage, and leakage of contents into the peritoneal cavity, aspiration, fistulation. So these are some of the complications that can occur with enteral feeding. And you can, of course, arrange home visits to help the family how to do this in their own setting. So another common complaint that these patients will have would be nausea and vomiting. This is going to be multifactorial. Sometimes it may be due to the effect of the tumor itself, following surgery, or following chemoradiotherapy. So therefore, we need to assess thoroughly for what the contributing cause is. So for management, you can do some of the non-pharmacological and pharmacological treatment options. So non-pharmacological things are actually small measures we can take to reduce this nausea and vomiting. So control of malodor, especially in the environment, which can cause an aversion to the patient, and advising them to avoid larger meals because post-gastrectomy they lack that reservoir, and avoidance of exposure to food odor that they find a bit unpleasant, and allowing them to have their meals in a calm environment is also beneficial. So pharmacological treatment, when we consider if there are any causative drugs which can be discontinued and can cause nausea, you can always think about it. And antiemetics are useful. Options that are available are hyoscine butyl bromide, olanzapine, metoclopramide, domperidone, promethazine, and ondansetron and aprepitant are actually quite useful in chemotherapy-induced nausea and vomiting. So, post-gastrectomy, patients develop many complications. So, post-vagotomy diarrhea is quite common, and it's thought to be due to the rapid passage of unconjugated bile salts from the denervated biliary tree into the colon, which can have sort of a osmotic diarrhea. So the management option they have is cholestyramine. And another common symptom is dumping syndrome after the resection of the stomach. So this is divided as early dumping and late dumping and has similar symptoms. So following a meal, they will develop GI discomfort such as nausea, vomiting, cramping, diarrhea, and some vasomotor symptoms as well, like diaphoresis, palpitations, and flushing. So early dumping develops about 15 to 30 minutes after the meal and is actually due to the osmotic effect the meal has on the small intestine, which can lead to the secretion of some vasoactive substances. Whereas late dumping will present hours later, and this is due to this insulin spike that can occur due to the rapid transit of the food. So how can we advise them about managing? We can encourage them to have frequent small meals rather than large meals at usual meal times. And a diet high in fiber and protein and low in carbohydrates has also proven to be beneficial. But if it's quite troublesome and is not responding to these things, we need to refer them. And the severe cases can be treated with octreotide and sometimes may even need reoperation. So nutritional deficiencies are quite common after gastrectomy, commonly iron and B12. So we can monitor and supplement when necessary. They can develop dysphagia in intestinal obstruction due to scar formation. So if they present with symptoms suggestive of intestinal obstruction, you need to quickly identify and refer. So the next important thing is management of pain. So pain again is going to be multifactorial and is one of the most essential components in the continuity of care of any terminally ill patient, especially in cancer patients. This could be related to the disease, treatment, or debility, or even other pre-existing causes like arthritis or something they have already had. So management is going to involve a comprehensive assessment. So we need to first assess how severe is this pain, and pharmacotherapy can be prescribed depending on the severity. So what we use is the WHO analgesic ladder, which we are all familiar with. This has 3 steps. So in the first step, what you can prescribe are opioids or non-opioids for mild to moderate pain with an adjuvant. In the second stage, non-opioids along with opioids you can prescribe with an adjuvant. And for severe pain, you can prescribe an opioid with a non-opioid along with an adjuvant. So what are these opioids? What are the non-opioids? What are adjuvants? So non-opioid plus or minus adjuvant is the first step. So non-opioid oral analgesics include paracetamol and NSAIDs. The paracetamol, how frequently can we give? You can give 500 to 1 gram oral 4 to 6 hours hourly. A maximum of 4 grams per day or 15 milligram per kilogram in a patient with body weight less than 50, like the usual dose. The NSAIDs that can be given are ibuprofen 5 milligram per kilogram 6 hourly or diclofenac sodium 1 milligram per kilogram oral 8 to 12 hourly. Up to a maximum of 150 milligrams daily, you can give diclofenac sodium. In the second step, for moderate pain, we use a weak opioid plus or minus step 1 medication, that is non-opioid with or without an adjuvant. So options here are tramadol, you can give 50 milligrams oral 6 hourly, or paracetamol codeine combination can be given every 6 hours. So step 3 is reserved for patients with severe pain, where we use strong opioids plus or minus step 1 medications with an adjuvant. So this is generally done with consultation with a specialist. So oral morphine IR, intermediate release, is actually the recommended drug. And sometimes you could directly go to step 3 when patients present with severe pain and consider de-escalation when the pain is adequately controlled. So it's important to regularly review and titrate the dose requirement to assess for side effects and pain level. This is something, even though the decision to start is to be made by a specialist, this is our involvement in pain management. It's important for us to keep in mind the side effects of opioids, especially ones who are on regular doses. They can develop constipation, nausea, vomiting, and sedation. They can get delirious, respiratory depression, even it could be rare with appropriate dosing, but can occur in patients who have cancer cachexia, and of course they can develop dependence on the opioids. So as I mentioned, the adjuvants are other drugs which can sort of augment this analgesic effect. Commonly used ones are amitriptyline or nortriptyline, carbamazepine, or gabapentin. These can be used along with the other drugs in any of the steps. So there are some non-pharmacological aspects we can consider in the management of pain. So physical pain, physical measures that can be done would be bed rest, immobilization, traction, bracing, and certain treatments like physiotherapy, cryotherapy, exercise, transcutaneous electrical nerve stimulation. Those are things that can be done. And of course, psychological. Educating the pain about the source of this pain and how it arises sometimes can actually help them to come to terms with it. Encouraging them to engage in recreational activities and relaxation therapy, meditation, music therapy, counseling have all proven to be beneficial. And sometimes they can be referred for palliative surgeries to reduce pain, including fixations and decompressions. And radiotherapy, especially for bone metastasis causing bone pain, has been quite effective. Certain complementary treatments like acupuncture, massages, aromatherapy, herbal therapy can also be tried because there would be no harm. And as I said, one of the most important aspects at which we could get involved is the psychological and spiritual well-being of both the patient and the caregiver. So what are the common problems you would see in a patient with cancer, like in a gastric cancer patient? This is a very serious diagnosis, and as I said, they could be at an advanced stage at the diagnosis. So they will develop issues of self-esteem and find it very difficult to adapt to the illness and its consequences. They can lose hope, lack purpose and direction. They can develop dependency and passiveness induced by being cared for, because they would stop thinking for themselves and just passively start to existing. They will have a lot of fears about the future, their own, their family, children, and they will develop communication problems with family and health professionals due to certain complications. Therefore, they are going to have an increased need for coping strategies. So what are the things we can do as primary care physicians to help them? We have to encourage them to engage in their routine activities as much as the disease and the debility allows. Peer support groups are actually proven to be quite beneficial, even though we don't have a lot of peer support groups available in Sri Lanka. In other countries, peer support groups have proven to be quite beneficial for not only the patient but also for caregivers. Emotional support can be provided to the patient and the family both. Especially for the caregiver, they can have a psychological impact by seeing their loved one in suffering. They can develop anxiety, depression, and sometimes start to neglect their own health. So these are things that we can quickly intervene with. And we have to coordinate the care effectively within the service. That is, we refer them whenever is necessary by quickly identifying. Counseling can be arranged for the individual and for the family both, and refer them for appropriate specialized services, that is to a psychiatrist whenever is necessary. And as I said, respite should be encouraged for the caregivers because they tend to neglect themselves as the disease advances. They put the patient's needs before themselves. And in the case of an inevitable death, it's our duty to help family members prepare for the end-of-life care if inoperable. And during the bereavement period too, we can provide them with psychological support. And along with that, we can encourage them to engage in their spiritual activities according to their beliefs. It will be beneficial for both the patient and the caregiver. And of course, prevention of other complications like pressure ulcer formation, prevention of DVT, bowel and bladder care. So what we have discussed today is how a patient with gastric carcinoma can present to you. What are the etiological factors? What are the risk factors? What is the epidemiology of the disease? What are the common presentations? And when to suspect? How to investigate? How to manage them? And most importantly, what we as primary care physicians can do contribute in the management of these patients. So what is the take-home message? Gastric cancer is a common cause of death in the world and also in Sri Lanka. As I said, 2% of cancer deaths in females and 3% of cancer deaths in males are due to gastric cancer. Symptoms are vague and non-specific, while signs develop in advanced disease. So identifying early is necessary. Prognosis is poor due to late presentation, since early cancer is asymptomatic. The etiology of gastric cancer is multifactorial, but Helicobacter pylori is an important factor for distal but not proximal gastric cancer. Therefore, it can be prevented by successful eradication. The treatment of gastric cancer is multimodal and requires a multidisciplinary approach. And early diagnosis is the key for a better outcome, while the family physician has a vital role to play in the prevention early detection, and the management of gastric cancer. So these were the references that I used. And thank you very much for taking your time to involve in these interactive sessions. And I would like to thank Dr. Lalanta Senaratna for providing me with the guidance to conduct this session. Thank you. If you have any questions, now would be the time.
Thank you, Dr. Gayani, for that very informative presentation. I just have two questions. How do we say a loss of weight is significant? Is there any sort of a arbitrary cutoff value? That is number one. And number two, what are the screening tests that you mentioned? Is it like stool local blood or is the screening endoscopy? Thank you.
Yeah. So for weight loss to be considered significant, if there is a loss of more than about 10% of body weight over the period of 6 months, it's considered significant. And your other question is about screening, right? So a screening in the sense, in certain countries like Japan, where this is quite prevalent, they have these one-stop upper GI clinics. So what they do is, at an at-risk population, they conduct upper GI endoscopy because other investigations like, let's say, stool or cut blood or whatever would be non-specific. So with an upper GI endoscopy, you could directly visualize the tumor and take a biopsy also at the same time. So what they use for screening is upper GI for at-risk population. So in other countries, if there is like a familial cancer in the family, other members are also encouraged to undergo upper GI endoscopy as a screening measure periodically.
Thank you, Dr. Gayani.
Okay. Any other questions? Any other questions? In the absence of questions, Dr. Prabhat, can we conclude the session?
I think the year 3 registrars, you should have some questions. If the patients, if those patients, if they do not present with any GI symptoms, what is the way of presentation? If they don't have any GI symptoms.
They can present with symptoms like anemia.
Yes, this anemia is the, I think why the 3 registrars, they don't talk. It should be anemia. So if the patient has present with any symptoms and signs suggestive of anemia, and what are the next steps to rule out all these things? With the presentation, suppose the only presentation is anemia.
Yes, you need to figure out what kind of anemia it is. Commonly, what we say would be a iron deficiency anemia.
And then?
Can do stool for occult blood.
And then?
And also upper and lower GI endoscopy to rule out malignancy, especially.
All the, like not only just anemia in the sense, like all the investigation related to rule out all the causes of anemia, such as?
An iron study, a blood picture, and ESR2 to because in old age anemia may be a sign of any other malignancy and sometimes even diseases like multiple myeloma.
Hmm.
Mm,
The iron studies and especially the serum ferritin level,
ferritin. Yes.
blood picture, and then accordingly you have to think what's the next step. Then the next step would be if there are no obvious pretty sort of bleeding PR, then you have to go for stool for occult blood.
Blood.
So then only if the occult blood is positive, and then there's some anemia, and if the other risk factors, with or without the other risk factors, then you should do the way that other countries do. You have to go ahead with the upper and sometimes they do the low GI, upper and low GI endoscopy, especially the upper GI. Right? So that is how the people do. I mean, that is how you should do. And you have the the responsibility to do these things. This early detection is important, but if anemia means when you detect, there's some sort of not only sometimes with meds, because it should be a very chronic bleeding, not just bleeding, right?
Yes.
Okay. Anyhow, you did a good presentation, and it's as a first year registrar. Not only the set of slides will not enough. The way you present matters a lot. You actually, fulfill both, with a, I think you are a good fast learner because,
Thank you, madam.
because with the very first presentation, I asked you to do, these are the things you should do. You nicely, sort of caught everything and came with this presentation. Not only that, the way you present is very, wonderful and well planned, very well planned.
Thank you, madam.
I really appreciate the way you did. Okay.
Thank you, madam. Thank you for your guidance, madam.
Okay then.
Thank you, Dr. Gayani, again for that very interesting presentation. And thank you, madam, for guiding us as always. I think with that, we can conclude today's session. Hope to meet you all again in another 2 weeks' time. Until then, good night.
Good.
Thank you.